Okay, everyone, I'm going to get started. So good afternoon. Thank you for joining us today for the Clinical Trials Methodology course webinar series. Today's webinar is on sex as a biological variable in grant review. And before I introduce our presenter, I do want to mention that you can use the chat box if you have a question or comment, and you can unmute yourself by clicking on the audio icon to the right of your screen. Also, please remember to evaluate the webinar at the end of today's session. So our presenter today is Dr. Cheryl Bushnell. Dr. Bushnell completed her neurology residency training, stroke research fellowship, and graduate degree in clinical research at Duke University. After 6 years on faculty in the Duke Division of Neurology, she joined the neurology faculty at Wake Forest Baptist in 2007. She was Associate Director of the Women's Health Center of Excellence from 2008 to 2010, and in October 2010, she was appointed Director of the Wake Forest Baptist Stroke Center and led the Joint Commission certification as Comprehensive Stroke Center in 2013. Her clinical practice is focused on inpatient and outpatient stroke treatment across the continuum. Her research spans women's issues related to stroke, including sex differences, preeclampsia, and a registry to study maternal and newborn stroke. Her current focus is on post-discharge care for stroke patients, and she led the development of a new model of care using a nurse practitioner nurse care team, which was shown to decrease 30-day readmissions. She is co-PI of Comprehensive Post-Acute Stroke Service study called COMPASS, a pragmatic clinical trial funded by Patient-Centered Outcomes Research Institute, which compares an enhanced version of the Wake Forest Baptist Medical Center post-acute stroke model of care versus usual care in 41 hospitals across North Carolina. She is PI of the Western North Carolina StrokeNet Regional Coordinating Center, funded by the NIH and NINDS, and the Vice Chair of Research in the Department of Neurology. So thank you, Dr. Bushnell, for presenting today. So I will turn it over to you.
Okay. Thanks, Joy. I really appreciate the invitation to talk about this topic, and I want to thank you and the CTMC group for the invitation. So sex as a biological variable is a very interesting topic, and I'm coming at this from two perspectives. One, as someone who does research in this area, and another as a recent grant reviewer, where this is a really important aspect of the grant review process. And so I'll kind of combine both of those perspectives in this talk today. So I have no disclosures, and the objectives from a content perspective are to help everyone understand what sex as a biological variable really means, describe the purpose of this SABV, as I'll refer to it, and how it's reviewed by NIH grant reviewers, and then give examples of why this is important in preclinical and clinical research, touching on neurology a little bit, but mostly on stroke, since that's my background. So what is SABV, in addition to the why and how? We'll talk about that. First of all, I want to actually make sure we are all on the same page about the aspects of sex and gender. So the definition of sex is really related to the organism's sex chromosome complement, either XX or XY. This is reflected in reproductive organs and can affect all aspects of physiological functioning, which in many organisms also affects behavior. But gender pertains to social, cultural, and psychological traits that are linked to human males and females through social context. So gender is very different from sex, and I think that it's important to understand for NIH's perspective, they're generally referring to sex when they refer to the SABV. So the definition for sex as a biological variable is that the expectation is that scientists will account for the possible role of sex as a biological variable in vertebrate, animal, and human studies. And this was enacted to apply to the proposals that would be submitted January 25th, 2016 and thereafter. And I included the link to the notice for the SABV description below, and there's a lot of information about that if you want to read more, you can refer to that link on the NIH page. So more importantly than what is why, and it's because sex and gender impact health and disease in many, many aspects. And consideration of these factors in research informs development and testing of preventive and therapeutic interventions for both men and women. And it's also important to note that women account for roughly half of all participants in NIH-supported clinical research, yet a lot of the preclinical research had been focused solely on male animals and cells because it was more difficult to deal with females because of pregnancy issues. And so SABV addresses how males and females are both similar and different, and this is important when you're talking about health and disease. Other reasons why this is important is that adequate consideration and experiments and disaggregation of data by sex can allow for these sex-based comparisons. It's also important for transparent reporting of data by sex, and that's kind of the rigor and reproducibility aspect of preclinical studies. This could certainly inform clinical interventions, and it could be critical to the interpretation, validation, and generalizability of research findings. And as I mentioned earlier, it's a critical component of reproducibility. So how can you actually utilize SABV? And you can do this a number of different ways, and I'll talk at the end about some specific research designs. But it's important to incorporate SABV into the development of research questions and your study design, also in the data collection and analysis of results, and importantly, in the reporting of findings. So how does NIH ask the reviewers to consider SABV? Well, first of all, as far as strategies when you're writing the proposal, is to include a relevant review of the available literature on the influence of biological sex. So this is in respect to whatever particular research you're doing. It's important to articulate the justification for a single sex study, and that should be articulating a strong justification, not a stroke justification. Sorry about that typo. Also, consideration of the influence of sex in the study design, and some options are to include a stratified randomization of males and females in experimental conditions, and you can examine the treatment or toxicity effects of each sex separately. And it's unfortunate that we have to actually spell this out because it should be fairly clear that this is important, but unfortunately, it hasn't always been systematically incorporated into research. So NIH is being very specific about how this could be accomplished. So this diagram is actually the reviewer guide that we are given when we're looking at grants. And if you start right here with, does the study involve invertebrate animals or humans? The answer is yes. And if you take a look at if the study is intended to test for sex differences, yes, then they're going to ask if the design analysis is adequately rigorous to actually test for sex differences. So those are two different answers to that question there. And then I kind of increased the size of the top portion of that algorithm. So if it's not intended to study sex differences, then it wants to make sure that the investigators have included both sexes in the study. And then is it a strong justification for a single sex study, yes or no? And then does the proposal demonstrate plans to report data disaggregated by sex? And so that is also an area that can be acknowledged as a strength or a weakness in the review criteria overall. And, you know, it's really important that it's still a valid approach to study one sex for a particular research question. And sometimes that can be in the setting of established data sets, and especially large ones. And the single sex study could be proposed because of limitations of existing data. And it's fine as long as you have a strong justification for doing so. But I just included an example here of a single sex cohort study that's been studied for many, many years now, probably over 40 years. And they are on the third generation of the Nurses' Health Study. And it's been a very impactful cohort with, you know, studies of chronic diseases, studies of women's issues, breast cancer, a lot of aspects of women's health that really wouldn't be studied otherwise. And so it's a really important way of understanding research and asking research questions. And it's totally fine to include single-sex studies. And it's also important to disaggregate data by sex. And so this is expected whether the study was powered to detect sex differences or not. And it enables its use for further studies, such as understanding the male and female biology. It's a really important window for future studies. And then it includes the ability to control, or should include the controlling for sex in multivariate analyses. And they should also report sex-specific results. So these are the recommendations for how to report the data. I'm going to talk now about some reasons why sex as a biological variable is important, and just give you some real-world examples from both neurology and pharmacology. Important to remember that the brain is sexually dimorphic. Brain volume is actually greater in men, but controlling for total volume. Women have a higher percent of gray matter. Women also have a higher global cerebral blood flow. Regional blood flow, however, is inconclusive in terms of true sex differences. And then from a neurochemical standpoint, there are well-established sex-specific differences in dopaminergic, serotonergic, and GABAergic markers. And so clearly there are differences in male and female brains from a neurochemical perspective as well. The other really important finding from folks who've been doing research in sex differences for a long time from a preclinical standpoint comes from Louise McCulloch, and this was published in 2005, where they're looking at a potential neuroprotective agent. And if you look at the just at the bars there, you can see that the response in the vehicle versus the 7-nitroindazole is completely opposite in male versus female mice. So for the female mice, they actually had a worsening of their infarct size in this experimental stroke model versus the males that had a huge improvement in total infarct size with the treatment. So this is really important to understand. She also did a similar experiment with a different potential neuroprotective agent, the PARP1 inhibitor. And again, you see that in males, there was a strong positive response to this agent, whereas in females, it was a significant increase in total infarct size, so a worsening of their deficit. So this is two different agents with completely opposite responses in male and female mice. And some of you may remember going back to about 2012 or 13, the expose of zolpidem or Ambien, and the fact that gender-based therapeutics was really not a common practice. And so Dr. Woosley was advocating for looking really closely at the role of gender-based therapeutics in the clinical care of women in this article in the Journal of Women's Health. And a quote from him here is, "An example of gender-based therapeutics is the recognition that the dose of a medication should be different for a female, not because of differences in body size, but because of the gender of the patient." And really what he should be saying here is sex-based therapeutics and not gender-based therapeutics, because we're talking about a physiological and pharmacological response and not just a social or cultural role. So I think that it's been more widely accepted to use sex in that setting now than it might have been at the time you wrote this. So again, the 60 Minutes expose on Ambien was a really important turning point for sex-based research, and this was really huge because it turned out that the FDA had information on differences between men and women and in their responses to this drug. And it just hadn't been widely available. They just had been prescribing Ambien at the same dose for men and women for ease of use. So Larry Cahill, who is an expert in this area, said, so the assumption we're making that it really doesn't matter sex is not a valid assumption. It may not matter. It may matter hugely. The way we're doing business has to change. So this is a call for scientists to re-examine medical research, especially drug dosages based on sex. And so it wasn't really that long after this that the NIH came up with sex as a biological variable and incorporating this into their NIH applications for investigators. More real-world examples from stroke clinical research. I've been involved in this field for many years, and along with Matt Reeves and several other colleagues, we published a review in Lancet Neurology in 2008, kind of discussing all the different aspects of stroke where there are sex differences, including epidemiology and clinical presentation, medical care, and outcomes. So it was a pretty sweeping coverage of that topic. And then the Lancet Neurology editors came back to me in late 2016 and said, can you write an update on this topic? And I said, sure, but I'd like to narrow it down. And so along with several other colleagues, some of them the same as in the previous review, we looked at sex differences, but focused on the evaluation and treatment of acute ischemic stroke. And this was published in July in print form in the Lancet Neurology. And so there's a lot of interesting information in there. If you'd like to read more, I've got the citation at the bottom of this slide. But the bottom line is that we found women were more likely to have non-traditional stroke signs and symptoms. They're more likely to have stroke mimics, and they have longer door to imaging times. And the interesting thing is that those three outcomes are really all linked. If you have non-traditional stroke symptoms and signs, or if you're a stroke mimic, it's going to take longer to decide whether this is a stroke and whether it should be imaged. And so I think that's a real important take home from the review that we did. And I also should mention that our scope of the review was only from 2009 through the time that we finished writing this paper. So it does not incorporate all the literature that's ever been published on this topic. We were told that we could only review papers from 2009 forward. So given the time frame, this is what we found. Now, the things that we found were not substantial or consistently different across the sex was in the use of EMS, in stroke knowledge, in eligibility for or access to thrombolysis or thrombectomy, or outcomes from either treatment. And I will say that there is not a huge amount of literature on thrombectomy yet. but what we did was, look across the clinical trials that had been published on thrombectomy for acute stroke, and just wanted to make sure that there were no sex by treatment interactions. And so that's where the outcomes we found were not significantly different. Now, what we did also find is that many of these studies did not account for age, pre-stroke function, or comorbidities. And those are three factors that have a huge bearing on any time we find sex differences. So for anyone doing research in this area, those are three areas, it's particularly age and pre-stroke function, that really have to be accounted for whenever you're trying to examine sex differences in stroke. A totally different example of sex differences in the stroke population was through a clinical trial of uric acid levels and outcome in China. And this was the post hoc analysis of the China anti-hypertensive trial in acute ischemic stroke. And what they found when they looked at uric acid levels from over 3,200 patients in the trial is that these levels were higher in men than women, and that was statistically significant. And the higher uric acid level was associated with a decreased risk of poor outcome in men but not women. And so there's something about this interaction that was highly significant. And so, again, a difference not only in the physiological levels of uric acid, but also in how that level impacted outcome after stroke. And I should mention that uric acid is an antioxidant. So theoretically, higher uric acid levels would be beneficial. And in fact, the Yuriko ICTIS trial was a randomized controlled trial of 1,000 milligrams of uric acid plus alteplase. This was a European trial. The initial results showed greater efficacy of uric acid in women versus men. And they also did an analysis with serum biomarkers of kind of an antioxidant ratio, as well as imaging. And so they looked at the difference between the CT perfusion penumbra, or infarct core, I should say, on CT perfusion versus the diffusion weighted imaging final infarct volume 3 days later. And so they determined that if there was a significant enough difference, it was evidence of infarct growth. So they did look at the data disaggregated by sex. And what they found is that there were, again, interactions between treatment and serum uric acid levels, or the antioxidant ratio of allantoin to uric acid. And this was significantly affecting infarct growth, and it was only in women, not men. So one of the ways to tie this together from a physiological perspective is that women had lower uric acid levels to start with, and so they actually benefited from the extra antioxidant boost. Now, there may be more going on at a cellular level, but from a macro level, this is basically what they were finding. And it certainly had an impact on the infarct growth in these women, as well as their overall improvement. So that's just an example of a clinical trial, 2 different clinical trials. But I'm going to talk a little bit more about an observational study that I was involved in called Vale. And the main objective of Vale was to look at medication adherence in stroke survivors from a multi-center national longitudinal registry. And this was in collaboration with the Guidelines Stroke Hospitals. It was an IRB-approved protocol and required written informed consent, and it was generally a relatively mild stroke population, just to make sure everybody kind of understands the type of patients we're talking about. And so when we disaggregated the data by sex, we found that women were a little bit older. Women were 67, males were 64. Women had less high school, or were more likely to have less than a high school education, less likely to be married, less likely to be living with someone, and less likely to be working. And then the important thing we found was that there was no difference in ambulatory status before admission. So this was a good balance to have in terms of looking at outcomes. And it says that there's a statistically significant difference in NIH stroke scale, but it's hard to imagine with both having a median of 2 that this would be significant. So we were interested in quality of life, and we measured that with the EQ5D, which is a measure that includes 5 domains: mobility, self-care, usual activities, pain and discomfort, and anxiety and depression. And this is a valid scale that is used throughout the world, and there's a way of normalizing the value that you get from the raw scores. And so what we did was measure EQ5D at 3 months and 12 months in the Vale cohort. And what you can see is that women were doing worse. They were less likely to have no problems in mobility, in usual activities, pain, discomfort, and anxiety and depression. And then when we analyzed this at 12 months, we found that there was still a problem for women in terms of mobility, pain and discomfort, and anxiety and depression. And this was highly significant. So that's the raw domains in comparing men and women. And then we wanted to do a sequential set of multivariate analyses and modeling that would take into account different groups of variables that we thought would impact quality of life. And so we found this large gender difference, sex difference, I should say, here at with the unadjusted model. And then when we did the model 2, when we added in education, baseline, living and work status, adequate income, and insurance, there was an attenuation of this difference between men and women. And we added in model 3, model 3 is education. Model 4 is stroke versus TIA, the number of risk factors and the number of medications and NIH stroke scale. And so you can see that from models 2, 3, and 4, there really was not a huge difference in the way that it attenuated the sex difference between men and women. And then at 12 months, we had more variables to include. And so again, we have this largest initial attenuation from unadjusted to model 2 with age, race, and marital status. And then model 3 included, back to this one. Model 3 included education, living and work status, adequate income, and insurance. Model 4 also included, the clinical aspects. And then model 5 included other outcomes such as living and work status at 3 months, how that could impact the 12-month quality of life, income change, recurrent stroke, modified Rankin scale, rehabilitation and persistence of medication use. So you can see that there's, even when you get to model 5, you still have a slight difference, but it's almost gone. It's slightly statistically significant at this point. So this is just one way of looking at how different clinical, demographic, and outcome variables can impact quality of life and the difference between men and women. So in summary, women had significantly worse quality of life than men at 3 and 12 months. But this difference was attenuated with adjustment for all those different covariates I showed you. But the mobility, pain, discomfort, and depression domains were worse in women at both 3 and 12 months. Although we did not know the quality of life pre-stroke, this was, we thought, a window into future directions for intervening to improve quality of life after stroke. So that's sort of going back to what I mentioned at the beginning, that the disaggregated data can help you understand what might be happening in an individual group, men versus women as an example. Now, the other thing that I think is really important is that marital status might have a huge impact on quality of life, and the women in this study who had a stroke were significantly less likely to be married. So we did not have a good measure of pre-stroke quality of life, and that's one of the limitations of almost every stroke study, especially observational ones. But just something to think about as you're designing studies and wanting to understand sex differences. So what are some of the implications for not only grants, but also future studies? One thing that's clear is that women have been underrepresented in clinical trials. And so women actually account for less than half of subjects enrolled in just NIH stroke prevention clinical drug trials. And of course, the low participation in women limits the generalization of the results. I'll give you another example, the SPRINT trial, which was the study of aggressive versus moderately aggressive blood pressure lowering in primary prevention. They actually never enrolled more than 30% women, and they stopped the study regardless of that. And so there's still, even though the direction of the effect was the same in men and women, it was not statistically significant because they had a underrepresentation of women and therefore less power to show the impact of aggressive blood pressure lowering. So that's just, again, something to think about when you're looking at the results of clinical trials. So as you all know, NIH requires inclusion of women and minorities in grant applications for this reason, and that's been that way since the mid-90s. But this is just showing you some of the clinical trials that have been done for stroke prevention. And on the left-hand side, you have a lot of the carotid intervention trials. And then on the right-hand side, you have some of the antiplatelet trials. And you can see that the best proportion of women was in the AAA SPS, which was African Americans and stroke prevention. And so they actually enrolled more women than men in that particular trial. So if there's one take home for everyone that's listening, it's to read this paper, which was written by Janine Clayton, who's the director of the Office of Research for Women's Health. And she basically summarized everything that I'm talking about in this one article, applying the new sex as a biological variable policy to research in clinical care. And this was published actually not that long ago, 2018. So here's her recommendation. What should you do as a researcher? Add sex, gender, and male and female to your literature searches in PubMed, and you can also use GenderMed databases. She also recommends randomizing and balancing the sexes in the study and control groups. For pharmaceuticals, you can consult the FDA snapshot page for sex differences in drug metabolism and effects of recently approved drugs. So this is a very important starting point to understanding where things are with toxicity, side effects, and treatment effects for a variety of drugs. And then if you suspect sex differences, you can conduct pilot studies to determine whether powering the study to detect that sex differences is warranted. So this would be important if you're putting in an R01 to have preliminary data that can give you this kind of power And then in the analyses, disaggregate the data to see if there are any hidden differences from when you have pooled data with both sexes together. She also is listing here some research designs that could include sex as a biological variable. So you can have a single variable design, complete/fractional factorial design, randomized block, ancillary variable, 4-core genotype, hormone depletion/replacement, sex hormone receptor knockouts. Obviously, those last two are more preclinical, but again, I refer you back to this paper where you can read more about those different types of designs, and she also includes the sources, so you can read a variety of papers from investigators who have used those designs. Then she ends with sex and gender equity and research guidelines, and the first rule of thumb is to make sure you're using the correct term and select sex and gender carefully. Where subjects of research comprise organisms capable of differentiation by sex, the research should be designed and conducted in a way that can reveal sex differences. And then where subjects can be differentiated by gender, research should be conducted similarly at this level of distinction. And so I think in the age of gender identity, I think this is even more important to have more research that's specifically focused on gender. So future implications and the take home for today's talk is that sex as a biological variable is really important, and from an NIH review perspective, it's essential for establishing equity, rigor, reproducibility, and transparency in biomedical research. I think it's too soon right now since it started in January of 2016, that's just the review process. And so maybe some of those grants that were submitted in January of 2016 might just be getting funded, some are just getting started. So I don't think that we'll be able to really have a good feel for how the sex as a biological variable will impact results of studies and designs of studies, but I think we should really carefully track it because it could be extremely important for future trials, for future interventions, and just a better understanding of sex differences in physiology and biology. So I will end there, and I'd be happy to answer any questions. I'm going to stop sharing my screen at this point and hand it back to Joy and anybody else who might have any questions.
Does anyone have any questions? You can type it in the chat box or unmute yourself.
I'm sorry, I was a little late. How are you, Dr. Bushnell?
I'm good. Will, how are you?
I'm good. Have you had any experience yet in terms of getting feedback on a grant, whether you did or did not adequately address, like in a clinical trials grant, whether you did or did not adequately address sex as a biological variable?
I haven't submitted any trial grants, but I've reviewed some that they weren't trials, they were kind of a lot of them preclinical, some clinical. And it was clear that some of those investigators hadn't really thought about it at all. And so it really does get kicked back to them if they don't include sex as a biological variable in certain aspects of their design and analysis. And so that was definitely a point of discussion during the last 2 grant reviews that I was involved in. So I think it'll become even more important in the clinical trial submission process and review process. And so it's interesting. I went a few years without reviewing grants, and it was just completely different this year with the sex as a biological variable and the reproducibility and rigor. And it's really kind of helped, I think, the reviewers understand how they need to assess these applications. And hopefully the message is getting back to their investigators that this is really important and they need to think about it.
I guess to maybe think of like a very concrete example, if you were designing a stroke thrombolytic trial, can you sort of think how you might how sex as a biological variable might kind of factor into and in this case, I mean, I think one part of that answer would be, well, ideally the preclinical experiments had been done correctly using both young and aged animals of both genders. But, just sort of starting a new thrombolytic trial today, I guess in humans, how would you potentially approach, say, a plan for that? And I don't mean to make everything about acute stroke. It's just what I'm the most familiar with. And I know that you're familiar with stroke as well. So I thought maybe that would be an example we could talk through as a group, just to sort of maybe think of something a bit more concrete.
Sure. Well, I think first of all, you would hope that you would get an equal number of men and women enrolled, and one of the strategies is to stratify. And so if you are really concerned about making sure you enrolled enough women, you certainly can include that in your block design if that was really a concern. I don't think that it has been, though, honestly. I think most of the acute stroke trials have had a relatively even distribution of women. Where things have lacked is with carotid disease, where they're more likely to, men just are more likely to have carotid disease. So it's a prevalence issue. In acute stroke, I think we have it's an equal opportunity disease for both men and women. So then you get into whether there are issues with the analysis and with specific confounders that may affect women and their outcomes more than men. And so that's where the pre-stroke function, I think, is really critical. And if we can really assess that more carefully, I'm not sure that a pre-stroke modified Rankin is good enough, to be honest. And from a stroke perspective, if we're looking at more granular outcomes, we might want to look more granularly at the covariate that could predict that outcome, which is pre-stroke function. I know that they have, most trials have excluded anybody with significant disability prior to enrolling them at all. So that's kind of taken care of it. But when you deal with observational research, you always have that issue. Does that help?
Yeah. So I think the other thing that I think helps me is, I think one of the there's the sort of checklist in terms of what reviewers are supposed to consider. And I think one of the first parts of that checklist, and you probably went on this, but is there in terms of the pathophysiology of the disease or its relationship to the treatment, is there likely to be a gender effect? And I think in a lot of disease states, the answer is, the answers here are potentially yes with data, no with data, or maybe. And I think a lot of times things fall into maybe. In terms of, you could say, maybe the thrombolytic interacts with estrogen. So you would think that premenopausal women may have either an augmented or attenuated effect from that thrombolytic, in which case it would be very important to potentially do stratified analyses or do some form of disaggregation. However, if you are limiting your population to postmenopausal women for whatever reason, not saying that that's right or wrong, then that might be, in terms of that mechanism, it may be sufficient to say that this is a biologic rationale for not, considering using I guess what I would say is a harsh clinical trials measure, which would be something like enforcing balance. We want the research to be equitable, but as you point out, if you tried to enforce 50-50 balance on carotid disease in the neck for men and women, that would be a problem. Similar to if you were enforcing, since many people of Asian descent have more intracranial disease versus neck disease, you would also have there can be biological reasons for differences in recruitment depending on the inclusion criteria. So I guess the thinking on the in terms of the trial, you need to sort of, I think the way that I think about this is think about, could there possibly be a relationship to sex as a biological variable? And if so, how does it influence your treatment? If you don't think there is, don't just say that I don't think TPA interacts with women or gender. Actually search the literature and be able to establish, here are the known potential heterogeneities with this molecule based on gender or estrogen status, and or sex and estrogen status. And they seem to be very modest effects. So as such, we don't feel that this is something that needs to be accounted for in the trial. Or they have huge effects, and we're going to say we need to actually have an adequately powered subgroup of females in this trial, because it's possible that this could work. This drug could work in females and possibly not males because of these things.
Mm-hmm.
So
Mm-hmm.
I think it requires some thoughtfulness. Elizabeth Kirkland asked whether it would be okay to simply block randomize and include it in the analysis. Again, putting gender, if you want to have balance on gender, then putting it in as one of the criteria to do block randomization would be a good way of keeping balance. But in a clinical trial, particularly one in multiple sites, you can only balance on so many factors. You may want to be balancing on center, and then do you want to try to make gender balanced within center? And that becomes a harder and harder problem across a large clinical trial where sites may be enrolling somebody every month, to have those those sort of differences in terms of different randomization tables. Now, if it's a treatment that has a strong potential sex-based interaction, then it would be really important to make sure that representation is good and the design is attuned to it. But to me, I think you have to be thoughtful, and I would avoid assuming there isn't a relationship. I would try to verify that. It's hard to prove a negative based on the literature, but if it truly hasn't been researched and you can't find any sorts of heterogeneity by sex in terms of the treatment or the biomarker or these other things, then it's worth saying we extensively searched the literature for this, and at this point we're unable to identify something. If you missed it, somebody will point it out to you, and if it hopefully you're good enough at searching, people are good enough at searching the literature, you'd find salient, high quality research that would be relevant. So that's a fairly long-winded soliloquy on it, but I think it's a lot of it's being thoughtful as to how things could potentially influence. But you're right, in a large clinical trial, if there was a sex-based effect, the TPA was much more effective in women. Most thrombolytic trials would not be powered to detect that. They're mainly powered to detect over the whole population. So
Right.
it could be an interesting hypothesis, but I think, as Elizabeth points out, saying that we will perform these stratified analyses, plotting of subgroups with 95% confidence intervals, an appropriate approach to looking at heterogeneity of treatment effect by gender. I think having those things as part of the plan in your sort of section, but as a reviewer, it's helpful to just, if you have a bit of a section in sex as a biological variable in the approach or in the significance where you're reviewing the preclinical data, then you can kind of cover those things, and I think you're going to come out ahead on the grant review in that area. Even if, but I think the thing that you must avoid is to just sort of say to yourself, it's obvious that sex is not play a role in this study design and this trial, and not even mention it at all, because I think that's, I think you need to think about it, and you need to think out loud and show your work. I guess, sort of invoking my kids who are in, 6th grade math, you can just write out the answer, but if your answer is it's not relevant and you don't say that or show your work, then I think that's a problem, because the reviewers aren't going to necessarily intuitively know that. I think particularly as this has gone through in more and more reviews, I think a couple cycles ago, these things might have slipped through the cracks in certain places, but it's really strongly written into the review criteria. The scientific review officers are querying that after people have done their major reviews, and really say that needs to be factored into how people are providing a priority score on the approach. So I think it's very important, and I think we need to continue to do better. But I think if you're thoughtful and scientific about it, I think, and you can get that across in a few sentences or more if you need to, based on the disease, then I think that will be, I think you'll come out ahead, I think, of where things are right now.
Yeah, I agree. A lot of it is just a way of forcing investigators to think about this as they're designing their application, and especially the approach. So that's, that's where you can get extra points theoretically, and also allow the reviewers to give you the check mark that you've thought about it and you've incorporated it the best that you can. And so, I reviewed a grant where the investigator said, when we inject this drug into female mice, they have a much stronger response than male mice. And then yet they didn't follow through on that and talk about how that would implicate, or how that would address their approach. And so, left me hanging. It was like, well, what are you going to do with this now? So it has to be just sort of across the board, applied to all aspects of the approach, and not just, a lot of times what I've seen is just a kind of mention to say that they've mentioned it and not really thought about it. So any other questions?
Did you see the one in the chat box?
That was Elizabeth.
I started
that one, okay.
I started to address that. And I guess in terms of the latter part of that, with grant page limits, it seems difficult to spend much time on the lit review if it wasn't the main focus. Yeah, again, I think you should be thoughtful, but depending on the disease in question. And Elizabeth is in my small group, and she's doing, Dr. Bushnell, I think you would appreciate it, a study looking at home self-monitoring for diabetes and blood pressure in primary care clinics in underserved areas in South Carolina to look at the reduction in risk for stroke and other cardiovascular disease. I think in that very specific example, it's very important, as you point out, to aggregate by, to basically in my study where I'm doing text messaging to reduce blood pressure in emergency department, people discharged from the emergency department in Flint, we are absolutely stratifying by gender to make sure that, we have balance in terms of our treatment groups in, men and women, because we do believe that how people will respond to text messages to motivate them to treat their hypertension and home self-monitoring techniques, we have a fear that it may be something that men respond to less than women, and we may need to adjust our approach in men versus women. Not to be, we don't know. We do have some preliminary data that it's just been a little harder to get men to continue to text back in some of these other blood pressure studies. So that's, again, it wasn't required in the grant review process at the time that grant went in, but that was one of the ways that we addressed it. It did play into our mechanism, our perceived mechanism of our treatment effect, so we added it in as a stratification factor. But in terms of how much real estate, I think it really depends on how, I think it always deserves some real estate. The degree to which you would go into detail, I think, would have to do with how much it may have an important interplay on your treatment. And again, in my study, if it works really well in women, we are going to be working to try to make sure that we're recruiting enough men and women in our study. We think it's going to be easier to recruit women, but we don't know that for sure. So that's something that we verified. So it can possibly go into other sections of your grant as well. So I think,
yeah, that's right.
I gave a 5-minute answer to, yes, that was sufficiently answered. So Elizabeth knows that I'm talkative. So, all right, any other questions from the group? Joy, did you want to put up the link for evaluations?
Yep, I just did.
Oh, perfect. Okay, you can see that in the chat box. And I just, we will be, recording, we've recorded this and we'll be posting this online for our course participants. And I really, really want to thank you, Dr. Bushnell, for making the time to talk to us today. And Joy, did I miss anything else?
I just wanted to remind everyone that our next webinar is on September 10th on good clinical practice. So,
oh, yes.
See a reminder for that over the weekend.
All right.
Thank you, everyone.
Thank you so much.
Thank you.